الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Travel Medicine Clinic, one of the occupational clinics by Professor Mahmoud Hani Sulaiman. Goals: introduce travel medicine. What is travel medicine? Provide basic information on conditions encountered during travel. Provide basic information on how to protect travelers, how to prevent these conditions. Increase awareness of resources containing practical and up-to-date travel information for specific patients. Each year, millions travel to or from countries with health risks, poor sanitation, and unusual infectious disease. It is recommended that these travelers to see their occupational health physicians before travel. Those who are going to travel must see their occupational health physician before travel. Reasons for a pre-travel visit: identify risks, protect against infectious and non-infectious conditions, fulfill requirements, update routine vaccinations, evaluate active medical conditions that might impact travel. Pre-travel visits: questions to ask your patients. The patient must declare the answers of these questions clearly. What countries and what areas are you visiting? How long will you stay? What types of activities do you plan? What vaccination have you already had? What medical conditions do you have? Do you have any allergies? Could you be pregnant? Vaccines: often recommended, sometimes required. Proof of vaccination needed to enter destination country. Proof of vaccination needed to enter destination country. Yellow fever and Saudi Arabia: if you travel during pilgrimage seasons, you must have certain vaccines. International certification of vaccination: if a vaccine is required, this is the best way to document it was given. We will begin by exploring a condition called jet lag. Jet lag. Jet lag and chronobiology. Jet lag equals syndrome involving insomnia or excessive daytime sleepiness following travel across at least 2 time zones. Jet lag is a syndrome of symptoms manifested by physiologic adaptations occurring when body shifted to a new time zone. Travel fatigue is a complex combination of physiologic, psychological, and environmental factors that develop during travel. It may accumulate over the course of a season and decrease workers' capacity to recover and perform. Chronobiology is a field of biology that study cyclic phenomena in living organisms and their adaptation to solar and lunar related rhythms. These cycles are known as circadian rhythm. Physiology of jet lag. Average human has endogenous cycles of energy, mood, and activity that last about 25 hours. Primary pacemaker is suprachiasmatic nuclei of hypothalamus. Suprachiasmatic nuclei of hypothalamus. When traveler changes time zones, this pacemaker must undergo entrainment, which is a process of resynchronization with new environmental light-dark cycle. Alternate light and dark cycle. Physiologic mechanisms involved in this process include melatonin adenosine, caffeine, neural pathway from retina, blue wavelength light, arginine vasopressin, Z-Gabris. So these processes include melatonin, which is a hormone typically secreted at dusk by pineal gland, helps body to anticipate daily onset of darkness. Adenosine accumulates when person is awake and causes progressive sleepiness. Adenosine accumulation blocked by caffeine, direct neural pathway from retina. Blue wavelength light interfere with sleep cycle through arginine vasopressin. Z-Gabers equal environmental cues that help reset pacemaker include light, temperature, exercise, social interactions, eating, drinking patterns. Disorders of circadian rhythm are most commonly happen in setting of a jet lag, when a new sleep-wake cycle is required on entering a new time zone. Symptoms and signs of jet lag include changes in mood, headaches, digestive difficulty, increased susceptibility to illness. Workers suffer from decrease in cognition, concentration, visual acuity, and memory. These changes often have adverse effects on physical fitness and performance. Rate of adjustment to a new time zone is a day for each time zone crossed. 1 day for each time zone crossed. Most of health complaints of shift workers related to quality of day sleep after a night shifts, and to lesser extent to sleep before morning shifts. Circadian rhythm programmed for daytime work and for nighttime sleep. After night shift, body is not completely tuned for going to sleep. Circadian rhythm disturbance leads to decreased sleep length and quality, negative mood, and GIT disturbance. This is the circadian rhythm. It contains biorhythm models use 3 cycles: a 23 physical cycle, a 28-day emotional cycle, and a 33-day intellectual cycle. Prevention of jet lag and travel fatigue. A structured worker travel program. A structured worker travel program. A structured worker travel program that encompasses pre-flight, in-flight, and post-flight periods is first step to establish effective control of travel fatigue and jet lag. Because there is no physiologic adaptation with repetitive time zone transitions, each long-distance journey requires its own specific travel strategy based on direction of travel, duration, and times of arrival and departure. Also, fatigue monitoring workers can help decreasing travel. Fatigue monitoring of the workers can help decrease travel-related physiological and psychological issues and decrease symptoms and signs and improve overall performance of the worker. Preflight component. Although it may be difficult because of schedule restrictions, introducing a schedule within 7 days of travel is optimal. Introducing a schedule within 7 days of travel is optimal. Consider gradually changing sleep-wake cycle and meals to the new time zone by shifting an hour per day. Consider adjusting work times to destination time zone. Avoid bright light for about 3 hours before bedtime. An emphasis should be placed on getting enough sleep before travel to reduce sleep debt. In-flight component. If they have not already done so, Advise workers to adjust their schedule to be in synchronization with destination time zone as soon as they board the plane to assist them in preparing for destination, e.g., watches, meals, and sleep schedules. Maintaining hydration is a priority. Avoid light projecting devices as computers, tablets, and movies. Post-flight component. Post-flight period stretches 2 to 4 days or more beyond arrival. During this time, activities of the worker like meals, sleep, rest, recovery should be planned by medical staff to accommodate rapid circadian adjustment. Most effective intervention is combination of scheduled light treatment, light avoidance, and melatonin. Additional fatigue countermeasures are use of napping and caffeine, both of which can synergistically improve alertness and decrease symptoms of fatigue. Pharmacologic measures. Melatonin. Melatonin aid in managing jet lag symptoms, both pre-flight and post-flight. Pre-flight low doses, 0.5 to 1.5 milligram of melatonin are most effective, whereas higher doses, even reaching 5 milligram, are recommended after flight. Pre-travel melatonin may be used to gradually shift feeling of dusk and bedtime to the anticipated time zone. Doses taken 30 minutes before bedtime on night of travel and initial about 3 nights after arriving at destination. This mitigates sleep disturbances associated with jet lag while increase circadian adaptation. Sedatives. Workers not suffering from jet lag or who do not respond to melatonin and experience 2 days of insomnia on arrival will likely benefit from use of medium acting, about 30 minutes, or medium half-life, about 6 hours, sedatives, e.g. temazepam. Very short acting ones, less than 15 minutes, short half-life 4 hours, sedatives, e.g. zaleplone, can be useful for sleep during flight. Caution must be exercised with in-flight use of sedatives because they may increase risk of deep vein thrombosis and decrease responsiveness in event of in-flight emergency. Stimulants like caffeine and other stimulants, e.g. modafinil, may be useful in combating fatigue. Caffeine. Use of caffeine till 200 milligram pill or beverage with 30-minute nap is effective in improving cognitive function in sleep-deprived states and at the lowest point of the circadian cycle. Non-pharmacologic measures. Pre-adaptation and light treatment. Light exposure is primary cue for circadian rhythm. Bright light exposure in morning will help to advance body clock, while exposure in late evening will help delay it. Attempts to shift circadian rhythm with pre-flight exposure to bright light before departure is successful during both eastward and westward travel. Exposure to natural bright light promotes circadian shifts. Avoidance of bright light, especially short wavelength blue light in evening, may help with shift for eastward travel. Use of blue blocking glasses as amber safety glasses may diminish this exposure. Workers should be cautioned to avoid evening use of tablets, computers, televisions, and mobile phones in order to minimize blue light exposure. Sleep. Sleep can be used to adjust workers' circadian rhythm before travel or decrease symptoms of sleepiness upon arrival. Shifting sleep schedule about 2 hours toward destination time zone in days preceding departure may shorten duration of jet lag. In addition, napping, discussed as a potential method to mitigate symptoms of jet lag. Best time to nap in flight or post-flight is nighttime in destination time zone. Power naps 20 minutes do not result in sleep inertia and may decrease daytime sleepiness in individuals experience jet lag. However, naps of more than 20 minutes may delay sleep adaptation and slow resynchronization. Deep vein thrombosis and travel. DVT is a condition where blood clot develops in deep veins, most commonly in lower extremities. A part of clot has the potential to break off and travel to lungs, causing a potentially life-threatening pulmonary embolism, PE. Prolonged periods of inactivity caused by space limitations may diminish circulation and produce lower extremity edema. Prolonged sitting with bent knees compresses popliteal veins, which is another potential risk factor for clot formation. Economy class syndrome equal long distance air travel was associated with a fourfold increased risk of venous thromboembolism, VTE. Venous thromboembolism, VTE, including deep vein thrombosis, DVT. DVT and travel continued. Environmental factors in flight as low oxygen, low humidity, low cabin pressure will lead to dehydration, which concentrate blood. This is worsened when passengers consume alcohol or do not adequately replenish fluids lost due to dehydration. However, there is no evidence that dehydration is directly associated with VTE. Certain reports suggested that flights of more than 8 hours increase risk of VTE in presence of additional risk factors in a patient. Other risk factors are age more than 40 years, obesity, and estrogen use. Workers in general good health are at a lower risk of VTE. A DVT mostly originates in calf with persistent cramping that intensifies over several days. This pain is accompanied by leg swelling and discoloration. In most cases, travel-related VTE occurs in first 2 weeks after travel. Risk returns to baseline after 8 weeks. DVT and travel continued. Treatment, early detection, and anticoagulant drugs as heparin, low molecular weight heparin, and warfarin. Prevention, maintaining hydration, exercise, and wearing support stockings may help decrease risk. Periodic activity with about every 2 hours include isometric exercises, walks along aisles, or stretching exercises. Below the knee graduated compression stockings that provide 30 mm mercury of pressure advocated as a preventive measure. Drugs as aspirin have antithrombotic properties but not recommended as a prophylactic measure in otherwise healthy individuals. In-flight medical emergencies. Occasionally, any physician can find himself called upon by a flight crew to evaluate a passenger-developed medical issue. A physician may determine that he can treat and stabilize the case of that patient, or he must wait till emergency landing done to treat him at land. Typical airline first aid supplies include stethoscope, blood pressure cuff, oral airways, bag masks, CPR masks, IV supplies, gloves, needles, syringes, antihistamines, oral and injectable, atropine injection, albuterol inhaler, aspirin 50% dextrose injection, aspirin 50 dextrose percent injection, epinephrine injection, lidocaine injection, nitroglycerin tablets, and AED. Preparing a medical plan for travel. Determination of contents of a medical kit will depend on numerous factors, including quality and availability of health care at destination, sport being covered, and potential injuries. In more remote locations, in developing countries, inclusion of sterile equipment should also be considered because these may not be available. For international travel, physicians should carry following documents: letter from team requesting medical coverage, list of medical supplies including medications being transported, medical license and passport, list of local medical contacts. Continued preparing a medical plan for travel. Travel medical insurance coverage should consider 24-hour physician-backed support center, network of referral providers, guarantee of medical payments abroad, direct pay to foreign hospitals and physicians, second opinion requirements before emergency treatment or surgery, coverage of higher risk activities, coverage for pre-existing conditions, and medical evacuation facilities. This is a sample of inventory list for travel medical supplies, documents, medications. Please print it and use it. This is the continued medication and may be considered if athletes are not drug tested, if workers are not drug tested, corticosteroid, injectable, decongestant, jet lag medication, supplies. Overview. First, we will begin with specific diseases. Second, travel advice. Third, special situation. These all are components of travel medicine. These are infectious agents associated with international travel, and the occupational physician must consider to vaccine his customers with these vaccines if they are traveling to an area where these diseases are present. Please write it and use it. This is disease acquired through vector exposure. If the vector is present in the places to where the travel is, please put a plan for prevention of these diseases. Of course, you can look at these diseases at the section of infectious diseases. Specific diseases as traveler's diarrhea, malaria, hepatitis A, typhoid, polio, cholera, meningococcal meningitis. All these diseases you can look at the lectures of infectious disease, communicable disease. Traveler's diarrhea, what is it? Loose stools lasting 1 to 4 days, usually caused by bacteria as E. coli. Is my traveler at risk? Occurs in 40 to 60% of travelers to developing countries. 30% confined to room per bed. 40% must curtail scheduled activities. Older travelers at higher risk for dehydration. Prevention and protection of travelers' diarrhea. Avoid unsafe food and water. Carry an anti-motility agent such as loperamide. Carry an antibiotic as quinolone to take if diarrhea occurs. Malaria, febrile illness caused by Plasmodium, a protozoa which infects human red cells and liver. Mosquito vector mostly bites from dusk to dawn, potentially fatal. Prevention of malaria, inspect precautions. Medication decrease malaria risk, provide a prescription for appropriate medications along with instructions on how to take them and what side effects may occur. Travelers should start taking the medications before traveling to the area and continue after leaving the area. The exact schedule and dosage varies according to the medicine used. Please refer to lectures about malaria. Malaria chemosuppressive regimens according to geographic area. That is, please print it and use it for your patient. Medications to prevent malaria include otavacone, proguanil, mefloquine, chloroquine. These are all pills. Write a prescription for the appropriate pill so the traveler can begin taking the medicines before being exposed to malaria. Chloroquine used to be our only option, but many countries have now chloroquine resistant. Malaria, atavacone, proguanil, or mefloquine are the drug of choice in areas with chloroquine resistance. There are other medications that are used in special circumstances as doxycycline. Areas where malaria transmission may occur and the areas with chloroquine resistance and chloroquine sensitive areas. Areas where malaria transmission may occur, please print and use. Hepatitis A, what is it? Inflammation of the liver caused by the hepatitis A virus. Fulminant disease may be fatal, spread by fecal-oral route. Is my traveler at risk? Risk as high as 1% per month of travel. CDC website and the lectures about hepatitis A. This is hepatitis A risk all over the world. Prevention and control, food and water precautions. Inactivated vaccine is highly effective and provides long-term immunity. Vaccination is recommended for travelers to developing areas. Gamma globulin is used for temporary protection in special circumstances. Please refer to the lecture section. Hepatitis A vaccine formulation. Typhoid fever. What is it? Bacteremia due to Salmonella typhi. Fecal-oral spread. Is my traveler at risk? Risk is about 3 per million travelers. Check CDC. Typhoid prevention and control, food and water precautions. Two choices for vaccination. Live attenuated vaccine given orally, injectable polysaccharide vaccine. Both provide 50 to 80% protection. Polio, what is it? Virus attacks motor neurons. Fecal-oral spread. Is my traveler at risk? Despite vaccine campaigns, some countries still pose a risk, but it is declared free now. Prevention and protection, a single booster shot inactivated polio vaccine IPV in adulthood for travelers to endemic areas. Travelers to Saudi Arabia during the Hajj may be required to show proof of vaccination. Cholera, what is it? Watery diarrhea caused by a toxin producing bacteria, Vibrio cholera. Fecal-oral spread. Is my traveler at risk? Very rare in travelers. Protection and prevention vaccine mostly not recommended. It is oral. Yellow fever, virus spread by a mosquito, causes hepatitis, sometimes fatal. Is my traveler at risk? Central and South America and Africa. Check website for destination specific risk. This is the areas endemic for yellow fever. In Africa and South America, the yellow fever belt. Prevention, insect precautions. Live attenuated virus vaccine is highly effective and recommended, has rare serious side effects. Vaccine only available in licensed centers. Vaccine is required for entry into some countries. Check these countries. Yellow fever vaccine, a single subcutaneous injection, contain viable attenuated yellow fever 17D strain virus, cultivated on chick embryo, efficacy 99%, validity begins after 10 days till 10 years, should be compulsory in yellow fever belt zone, given only after 1 year of age, fear of encephalitis, not given in first trimester, not given for immunosuppressed. Meningococcal meningitis, inflammation of meninges caused by Neisseria meningitidis, respiratory spread, traveler at risk, endemic in parts of sub-Saharan Africa in December to June. This is meningitis belt in Africa. Meningococcal meningitis prevention, polysaccharide vaccine recommended for endemic areas, vaccine required for travel to Saudi Arabia during the Hajj. Other disease, remind your patient, routine vaccination should be up to date, consider hepatitis B vaccination for long-term travelers, use precautions to avoid sexually transmitted disease, don't pet or play with animals, if bitten, wash wound and seek medical attention. We are still in the overview. Now we will explain travel advice for the traveler about food precautions, water precautions, insect precautions, high altitude care, motion sickness, accident avoidance, and packing tips. Food and water precautions. Food, it is unsafe raw or partially cooked meat or seafood, raw and peeled fruits and vegetables as lettuce and strawberries. Safer food, fruits peeled by the traveler himself, fresh bread, hot cooked food. Remind travelers to wash hands before eating and after eating. Water unsafe, tap water, food washed in contaminated water, ice. Safer water is boiled water, carbonated drinks, sodas, carbonated bottled water from a reputable source. Insect precautions, insect repellents containing DEET, protective clothing, mosquito netting if available, clothing or bed nests treated with insecticides. Please refer to the lesson about malaria. Altitude illness, what is it? Milder form, acute mountain sickness, causes headache, restlessness, nausea. More severe form, pulmonary edema or cerebral edema. Is my traveler at risk? Usually above 6,000 feet, though possible at lower altitudes. Protection and prevention of mountain illness. Ascend gradually. If mild symptoms occur, stop and rest. Descend immediately and seek medical attention if traveler has persistent symptoms, shortness of breath at rest, confusion or inability to perform tandem gait. Medications can reduce risk of mountain sickness. Acetazolamide. Motion sickness, scopolamine patches or antihistamines may prevent motion sickness. These medications have side effects, especially in older travelers. Dramamine. Accident avoidance. Motor vehicle accidents are the leading cause of death in travelers. Look both ways before crossing the street. Use seat belts. Accident avoidance. Long plane or car rides can cause blood clots. Walk around as frequently as possible and stay hydrated. Travelers packing list. Prescription medications in original containers in carry-on luggage. Over-the-counter remedies for headache, heartburn, etc. Sunscreen, insect repellents, bandage, thermometer, tape, tweezers. The third of the overview is special situations. Special situations, chronic illnesses, immunocompromised states, pregnant travelers, and traveling with children. Chronic illnesses should be stable before travel. Pack extra medication in case travel is extended. Medical alert bracelet and letter from physician are helpful. Letter should include diagnosis, medications, and doses. Diabetes insulin cannot be frozen. Pack in carry-on bag. Check blood sugar frequently. Irregular meals, exotic foods, infections. Adjust insulin for travel across time zones. Carry candy. Alert letter. Letter should specify the traveler will carry syringes and needles. Heart disease, avoid travel if unstable angina, active CHF, recent MI. Carry recent EKG and letter from physician. Scuba diving and mountain climbing involve extra strain, pre-travel conditioning. Immunocompromised travelers avoid live vaccine if significant immunocompromised. Response to all vaccines may be blunted in immunocompromised persons, also at higher risk for complication if they get ill during travel. Please refer to my lectures about infections and vaccinations. Pregnant travelers, numerous risks in developing countries. Malaria is more serious in pregnant women. They should receive expert consultation from an experienced professional. Please refer to my lecture about malaria. Many vaccines and medications are contraindicated. Traveling with children, check vaccine and medication doses carefully. Encourage hand washing. Breastfeeding avoids contaminated fluids. Children are at increased risk for many diseases and are easily dehydrated. وفي النهاية أقول الحمد لله و thank you for your good listening.